Thank you so much. Thank you, APO, AIOS, for this opportunity. So, first is going to be a patient with diplopia and ptosis. So, we have this 52-year-old male who has an acquired unilateral ptosis for the last 1 year, and this is how he looks like. He also complains that he has double vision, which is more when he's tired or in the evenings. So let's see how his ocular motility looks like, and I would like you to observe as to what's happening with the eyelids. Patient looks to the right, you see that maybe there is a limitation of abduction to the right side. You see the other eye also, other eye where there is no perceptible ptosis, you find that there is a little bit of hopping going around. You see when the patient looks down and makes an upward saccade, there is that little bit of hopping off the lid, which is called Cogan's lid twitch. And here, when you see that when you lift up a ptotic eyelid, you'll find that the other eye also going down. So this is a sign of ocular myasthenia. The features which will tell you that this ocular myasthenia is where the patient was saying that there was variability. The diplopia was more in the evening or when he was tired, and those funny lid movement. I'd like to demonstrate that a little further in this video as well. So again, a 34-year-old lady complaining of diplopia, and you'll find that when we are checking an ocular motility, she's not really able to move her eyes significantly in any direction, but you'll find that lid hopping, which is very significant sign when present, suggestive of ocular myasthenia. So Cogan's lid twitch when patient looks down and then makes an upward saccades after 20 seconds, and you'll find that there's a lid hopping, or when you're checking ocular motility and you find that the lid is really hopping, these are signs or suggestion of that the patient might be having ocular myasthenia. The other features that you look for would be a weak orbicularis oculi tone, and when you are checking ocular motility, you will find that the ptosis is increasing. So these are the features of ocular myasthenia. One of the important tests that you can perform in the clinic would be ICE test, and you'll find here in the top picture the patient has ptosis. Patient was told that this looks like aponeurotic ptosis. Please remember, as Rohit was mentioning, any squint that you don't understand, ocular myasthenia would be a part of differential. Any acquired ptosis, you generally would keep ocular myasthenia as one of the differentials. This patient was told that maybe you are having an aponeurotic ptosis, but you see how the eyes become near normal after the ICE test. Now what happens if we miss out on the patient or the diagnosis of ocular myasthenia? This is a young man, and you see the top two pictures are pre-op pictures. He presented with an acquired ptosis, though he was told that maybe your problem is a congenital ptosis and you should undergo surgery, you'll have good results. The bottom two pictures are after surgery. So he underwent a ptosis surgery. The myasthenia signs probably were missed up in the initial clinical examination. You find in the bottom picture that now patient has a scar, ptosis is not improved at all, and now patient also has a lid lag. Another unfortunate patient who came with ptosis and diplopia, and I'm sorry for this. Again, patient was told that ptosis is congenital ptosis. He underwent a surgery. You can see a scar on the right upper eyelid, and a month after surgery, his ocular motility was all over. Because the myasthenia, ocular myasthenia gravis was missed, surgery was done, and the disease progressed, and his eye movement was really very awry. And unfortunately, patient ended up blaming his ocular motility on surgery. Of course, I mean, he doesn't know that it's not nothing related to surgery. So that's the importance of making sure that we don't miss out on a diagnosis of ocular myasthenia. So that was the first case scenario. We're talking about ptosis and diplopia. Ocular myasthenia gravis, variability, those funny lid signs, fatigability when you see the patient, ICE test. When in doubt, you can do pharmacological tests. However, some of these pharmacological agents are not very easy to lay a hand on. And antibody test. Now, presence of antibodies would help that this is ocular myasthenia gravis. However, absence of antibodies in a pure ocular form does not rule out ocular myasthenia gravis, because up to 40% or 50% of these patients may not have all antibodies. Now, so we change gears. This is a 40-year-old lady, diabetes, diplopia with ptosis. and you find there is a right ptosis. She was told that maybe your problem is related to diabetes. She was also told that you have little cataract. She was telling that there's a little blurring, so that maybe you should undergo cataract surgery. You see what happens when you check ocular motility. When the patient looks to the left and right, ocular motility seems to be okay. See what happens when the patient looks up. You find that there is a limitation of elevation, and when the patient looks down, the depression is by and large okay. You see the right eye, there is a limitation of elevation. Anything else anybody noticed apart from ptosis and limitation of elevation? Any other? Yeah. You find that the pupil on that side is larger. There is anisocoria. So this is a patient who had partial third nerve palsy with involvement of pupil. This is a medical emergency. You are suspecting compressive lesion of the third nerve. Why it's an emergency? Because one of the commonest compressive lesion of the third nerve is aneurysm of posterior communicating artery. So this patient should undergo MRI with MRA. You want to rule out the aneurysm. There are other signs which can tell you that you are dealing with aneurysm, as happened in this patient. I'm sorry the video is not playing. Patient had third nerve palsy 6 weeks ago. No neuroimaging was done because the patient was told that maybe it's related to his really altered vasculopathic risk factors. However, when the patient recovered from the third nerve palsy, you found that when patient adducted, there was widening of palpebral fissure. When the patient looked down, there was a lid lag. These are the two signs of aberrant regeneration of third nerve. So apart from involvement of pupil, aberrant regeneration of third nerve also tells you that this is likely to be a compressive lesion. So, and these patients would require MRI with MRA. However, now there is a thinking that any third nerve palsy, irrespective of involvement of pupil or no involvement of pupil, should undergo MRI with MRA, because what you are likely to miss out is fatal. So that's about the third nerve palsy, and I'll give you some numbers, and that's the reason why the MRI is important, because 10% of these patients who develop third nerve palsy because of aneurysm, they can actually pass away before any medical attention is given to them, and 50% of them can die within first month, and the survivors are likely to have residual incapacitating neurological deficit. So that's about the third nerve palsy. This is an interesting patient, a 70-year-old gentleman who was a known case of Parkinsonism, and he was telling that I have some double vision and I also have ptosis. I have drooping of eyelid after I read. So initially we thought that maybe he has myasthenia, until we saw the patient and we recorded. And you see, it's a little long video, but you find that he's not really moving his eyes as briskly as he would like to. And there is a limitation of ocular motility, especially in the left eye. But his problem of closure of the eye, which he said, or he was told that, yeah, you have ptosis and diplopia, maybe myasthenia. See what happens, this is what used to happen. After he has read for some time, he would have closure of the eyelids, and then he has to really mechanically make sure that the eyelids open up, and that's what he did with the right upper eyelid, and you'll find that the left upper eyelid, after some flickering, would open up. So this is not really a ptosis, this was apraxia of lid opening, which is also can be a part of Parkinsonism, which sometimes can be confused with ptosis and diplopia. We have one more example of patient with ptosis and occasional diplopia. She's a lady who started having bilateral ptosis 3 years ago. She's a 21-year-old lady, and it was a progressive worsening of ptosis, which was near symmetrical. She had diplopia initially when she started having a problem, but after that there was no diplopia because the ocular motility was symmetrically affected. So this is an example of patient with CPEO. Chronic progressive external ophthalmoplegia can be isolated, it can be hereditary, or it can be a part of Kearns-Sayre syndrome, where the patient can have associated heart block. A similar kind of limitation of ocular motility, which can occur in older male, is myotonic dystrophy, where patient again can have bilateral ptosis with progressive ophthalmoplegia and myotonia of lid closure. They can also have effect on the pupil. They also can have glaucoma. And I'll end with the last example of ptosis with diplopia. This is a gentleman who had a sudden onset complete ptosis. Initially there was a diplopia when the lid was drooping. After that there was no diplopia, obviously, because there was a complete ptosis. And you find here when you check ocular motility in the right eye, there is hardly any movement on any side. So now when you have this kind of problem, when you have ptosis and limitation of ocular motility, you localize this lesion either to the orbit or cavernous sinus. Now a simple way to differentiate whether this problem is cavernous sinus or orbit is to look at the vision. If the optic nerve function is preserved, you are looking at cavernous sinus. If the optic nerve function is affected, you are looking at orbit. So that's about ptosis and diplopia. We looked at myasthenia, we looked at third nerve palsy, we looked at orbital or cavernous sinus lesion, and some of the rarer features like myasthenia and